Hi, Dr. Brian Kaufman, a family doctor turned patient with CLL here at ASHA 2014 in muggy San Francisco. Want to introduce yourself, Professor Roderick?
Yeah. My name's Dr. Andrew Robertson. I'm a clinical haematologist from Melbourne, Australia. Work at the Royal Melbourne Hospital and also at the Walter and Eliza Hall Institute of Medical Research, which is one of the places that was involved in the development of the drug we're talking about.
So we were just getting to some of the really exciting results, and you talked about a couple things. We were talking about response rates and progression-free survival. A couple things struck me. For a single oral agent to have a 20% complete remission rate, that's pretty amazing. I'm going to push a little bit on that. Do we have any MRD negative minimal residual disease? Have we looked at that? Do we know where we're at with that? And then also talk to us a little bit more about the progression-free survival, because one of the raps I've heard against ABT is that it has a short progression-free survival despite the depth of the remission, but it sounds like you're adjusting dosages to sort of to deal with that issue.
Great questions, Brian. Let's talk about the depth of the response. Some of the patients in CR do not have detectable minimal residual disease
amazing.
By sensitive flow cytometry. We don't have any data yet by even more sensitive molecular methods. What we do know, and that, look, I've got a patient on 150 milligrams a day, and that patient is MRD negative and has been in complete remission for over 2.5 years. Yet the dose that we're exploring is around the 400 mark. It looks more clinically effective on average for patients than the 150. It's clear to me that some people are exquisitely sensitive to this drug, and so maybe using a higher dose, we'd get a higher rate of minimal residual disease. In terms of durability, I think it's premature for anyone to be making any judgment whatsoever about what the durability of response is. You know, my patients who are responding well are anticipating that it's going to go on for a very long time. I don't believe that this drug's a cure, so please don't get me wrong. But once you get into a stable CR, particularly for MRD negative, this is playing out like it would appear to be playing out like it does for MRD negative after treatments such as fludarabine, cyclophosphamide, Rituximab. Too early to know that for sure, but that's potentially how it's looking. Now, there are a number of people who do progress relatively early on this, but the people going on the trial that I talked about are the people who have typically failed to respond or have only had a brief response to standard therapies, and so they're at high risk of developing Richter's transformation. And what we're seeing in the monotherapy trial is that the CLL melts away and you're left with one area of disease, and when we biopsy it, that's Richter's transformation. So
which may have been there when the patient entered the trial, and you've melted away the rest of the disease, and then it becomes apparent. It might have been a small clone.
Yeah, and that's a paradigm that's playing out with other targeted therapies, right, such as ibrutinib, alpelisib, etc. That's our working hypothesis. It's held up. The key evidence for that is when we're seeing this. Most of the disease that, as I said, most people going on the study have multiple areas of disease, often very bulky. Most melts away and you're left with one or two hard spots. Having said that, some patients have been treated for diffuse large B-cell lymphoma that is a Richter's transformation from CLL, and some of those patients have responded, and that's a different arm of the study. So I don't think it's as simple as saying Richter's transformation means this drug won't work, but I think if you are on this drug and it's been working and you develop Richter's transformation, well, clearly the drug isn't working on its own. And that's an argument for combination therapies. And at ASH this year, I'm reporting some updated results of our phase 1b study of venetoclax and Rituximab. It's a pretty logical partnership, and in preclinical studies in rodent models, we've been able to demonstrate synergy between the BCL2 inhibitor and Rituximab. And so we've treated 49 patients, all relapsed or refractory CLL, many of them heavily pretreated, perhaps not as heavily pretreated as the patients on the original study. And at ASH, I'll be reporting an 88% overall response rate and a complete remission rate of 31%.
Oh my gosh.
And half of the people in complete remission are MRD negative on their bone marrow using sensitive flow cytometric measures.
Now, this includes some 17p patients, I understand, too?
Yeah, about 20% of the patients on this combination study have deletion 17p, and about 25 to 30%, I just can't recall, on the monotherapy phase 1 study had deletion 17p. And patients with deletion 17p have the same overall response rate as patients who don't have deletion 17p. They also appear to have roughly the same complete remission rate. There is a slightly higher propensity to progress early because they're at higher risk of Richter's transformation, something that we've known for many years. But when you look at the totality of the data, patients with deletion 17p appear to be responding as well as patients who don't have such adverse prognostic features. Same is true for people who are fludarabine refractory, and same appears to be true for people with very bulky disease, more than 10 centimetres.
Now, we've talked about the tumor lysis syndrome. Has anything else come up in terms of adverse events now that you've got a little bit more experience with the medication?
Look, it's a generally very well tolerated drug at the 400 milligram dose per day that we're giving. Most people have no side effects, or they have some mild nausea or loose bowels. That's often transient. They either get used to having an extra bowel action a day. Most people don't need any treatment for that and generally say this is very well tolerated. Neutropenia is something that we've seen, so a reduction in neutrophil counts is something we've seen on this drug, and in heavily pre-treated people, about 50% of people are dropping their neutrophil counts. The rate of infection, however, which is the thing that patients, as you know, are most concerned about, is relatively low with this drug, and so we're pretty confident with the safety profile of venetoclax on its own, and equally so in combination with Rituximab.
Super. In the last few seconds, any final thoughts about the trial? Any advice to patients?
Well, at the moment, I would say if you're interested in this drug, you need to look for a trial. There's an ongoing trial in patients with deletion 17p CLL, that's ABT-199 on its own. There's also a trial for patients with relapsed or refractory CLL in combination of venetoclax and Rituximab, and it's been compared with bendamustine and Rituximab. And there's a whole host of other trials coming in combination with other medications. It's a very exciting time. We'll know a lot more in 1 to 2 years.
Professor Roberts, thanks so much.
Thanks for your time,
Thanks.
Brian.